Hello again. Good to see you all. We are 15 minutes away from the best part of the day, lunch. I know you've been waiting so long. Great conversations. Our topic and today is about primary care, the challenges that could face. And as we know, primary care are the frontliner of the health delivery of services. With me, I would like to invite colleague Prof. Shaili Barsad. He is the Carson Chair for Global Health and the Executive Director of the Center for Global Health and Social Responsibility at the University of Minnesota. Please give him a round of applause. Good to have you. From your perspective, what are the challenges that they face now, primary care on a global level, and how you could see that? So, you're an expert in that, and specifically when it comes to JB's family physician and all nurses who work on that directions too.
I'd like to start by saying that I'm boring. Primary care is boring. But boring is good in healthcare. We don't want too much excitement, right? And let's get back to that. And I know I'm coming in between you and lunch, so bear with me for a few minutes. How many of you walked over here today? Good thing to do in New York City, right? Particularly this week. While I was walking, there were a few things that struck me. One, the people, a lot of people. The second, a lot of advertisements. And healthcare advertisements. Look at our hospital, how beautiful it is. We have the latest blah, blah, blah. By the way, this is not unique to New York City. I've seen this in Thailand. I've seen this in Indonesia. Indonesia, it was about a partnership with a large hospital that won't be named here. In Korea, it was advertisements for plastic surgery. In Thailand, it was about some medical equipment. Now, in all of this, my primary question is this healthcare? It is, isn't it? It's still healthcare. But lost in this is the foundational element, primary healthcare. And yes, I'm a primary care doctor by training, so I got to talk a lot about my profession first. But I think in our conversations, we sometimes forget that health systems need to be built from the ground up. In many of the conversations around the world, there's a huge push towards universal health coverage. You folks know this by now. Not in the US. We don't have to talk about what we talk about in the US. We don't talk about primary health care in the US. But in the frameworks of universal health coverage, it would be possible to achieve that only if you build health systems from the primary health care systems up. And I want to emphasize this. The foundational element for universal health coverage to be made possible is by creating primary health care from the ground up. That's not where the conversation is. Very rarely are we talking about primary health care workers, not just physicians, primary health care workers, in the same way we talk about training the next generation of great surgeons. And this is a moral quandary. I get posed this question often. I was talking to a former health minister from Ethiopia. He was struggling with the premise that there was a kidney transplant program that was going to be opened up in Addis Ababa. And his point was, shouldn't we be concentrating more on immunizations and maternal health and childcare and things like that? And from me, the answer almost always is yes. I'm not in any way saying that people in Addis do not need kidney transplantation programs. They do. But can we first cover what is needed? And this, I think, is one of the primary problems we have in primary healthcare. Now, let's step back a second and say, how do we then analyze where we are with this? And I'd like to use a triangular framework. Forgive me, I'm a professor at heart, so I have to give some teaching points here, right? It's a triangular framework that was developed by a global engagement network for primary healthcare. And one part of this triangle, one angle of the triangle, are the factories, the academic programs that produce the workforce, right? This is very important to keep in mind. If you analyze places like, for example, the US, our factories are horrible. Our factories are really bad in providing the workforce for primary healthcare. Some of the big name universities, and I won't name them now, have 0 to 1% of the graduates going into primary care. 0 to 1%. My university ranks amongst the top in the country. Yes, I'm bragging, sorry. And we barely do about 17%. Whereas the need in the community is about 50% of all physicians, practitioners, be from primary care. We are not doing any of that. So our factories are to blame partly. And it bothers me sometimes when I hear that when I'm going to another part of the world, they say, oh, we are getting models from this particular university. I'm like, please don't. They're not really doing workforce management which are fit for purpose in their own neighborhoods. How do you expect fit-for-purpose activity to occur across the world then, right? And the second part about it is the market. The market, I don't have to emphasize too much here. The advertisements tell their own story, isn't it? The market is not valuing primary care. The economic analysis will definitely say yes. For every dollar, $10. There's a study out of Oregon that said for every dollar invested in primary care, you save $13. That's pretty good investment, I should say. Much better than what you get down in Wall Street. But we don't talk about it in the same way as, look, we have the latest Da Vinci machine in our neighborhood. By the way, our city has 5. Do we need 5? I have no idea. Because nobody has done the analysis whether the city needs 5 Da Vinci machines. The third part of the triangle, if you consider the market and the factory, is the policy. Where are our policies aligned? So I do feel, going back to your question, Ahmed, the challenges we face in primary care is one about identity, second about respect. I get no respect, dudes. I need more. Not just me, primary care does. And then how do we then analyze the situation in these 3 important aspects? And if you do that, we'll start having the conversation that's very important for us to keep in mind, that having the healthcare workforce based on strong primary care, not vertical programs alone, not agenda set by somebody else somewhere else, in a way that creates resilient health systems in communities.
You really identify the issues, and let's go practical and take you from your academic, and analogy into now we want to go practical. What are the strategies that has been showing a promise in tackling such an issue when it comes to primary healthcare?
Thank you. I think the practical is probably the most important. What are the places that have shown some benefit from doing this? If we move past the boring part of it, it is boring. It is not a new equipment coming, et cetera, et cetera. Some of the strategies that have shown to work include, like, for example, Costa Rica. I'll give Costa Rica as an example. Costa Rica did some massive changes in their approach towards healthcare in the mid-90s, and they emphasized the need for primary healthcare way before the conversation about universal health coverage was sexy in the rest of the world. And their important emphasis then was to look at teams of care, multidisciplinary care. The efforts that they've put in have been quite dramatic. The folks are living longer. Folks would live about up to the mid-50s before. Now the current, I think it's 81.3. That's pretty impressive. Cost of care has gone down a lot, significantly down. Mental health provision has improved significantly in communities, particularly from a multidisciplinary healthcare viewpoint. And so I do feel that we have that as a very solid example. There are places that are looking at the growth of primary care. Indonesia has decreed that a majority of the universities need to start training in primary care, which I think is an important step. Where there was no primary care training before, there is more emphasis being given. So I do see this as very strong positive steps in that direction.
Great. We want to talk about the development in this area. And the development is always have a great impact and negative impact at the same time. So how can we balance and measure that and make sure that actually primary care is going forward with the goal of health availability for all?
Yeah, I think we got to keep in mind as we talk about the growth of primary care, we sort of emphasize what primary care teams look like. Historically, clinical medicine has had the challenge of thinking about buildings and structures and waiting for people to come in. Primary care teams should go outside the buildings, right? It should be outside our clinics. It should be out in the communities. So how do you then fashion out plans where primary care is out there in the community, where you have extension of the work through community health workers, first-line workers, as previous speakers have spoken, and then also integrating it in a way to say what care needs to be escalated. Now, that escalation of care is a very important concept here, too. We don't want to assume that we don't need specialists. We absolutely need them. How do we appropriately use, because the specialists are also precious commodities, how do we appropriately use them? How do we trigger appropriate utilization? We shouldn't be getting routine hypertension management by cardiologists. Outcomes are shown to be more expensive, less productive, by the way, if you look at overall studies on chronic disease management. But who are the ones that need the specialist care? And how do you then trigger that response? That's a critical point for us to keep in mind. The second point about it is around telehealth. COVID taught us that telehealth is a provision that we can use. It also showed us some challenges. The main challenge, particularly in the US, was that not many people could access it. So the premise of telequity, equity through telehealth, is an important framework. How are we providing telehealth to all who need it? And then how do you then appropriately use telehealth to both vertically integrate into a specialist framework, or use telehealth as a bimodal transmission of information, both taking in information from patients and also using it as a way to disseminate important information. One of the things I forgot, and there was a mention in the prior panel about trust. We are at a unique time right now because trust in our institutions are at all-time low, right? Trust in governments are at an all-time low. Trust in physicians at an all-time low. Trust in healthcare is at an all-time low. And sometimes we have to ask the question ourselves, have we as healthcare providers contributed to that? What have we done to mitigate that? How much can we take on the point about continuing to work in a trusting manner, right? And in this, I feel that we have to keep in mind that a significant amount of healthcare used to be relational. It's become more transactional. So the shift from the relational to transactional is an integral part of understanding the dynamics of primary care. And if you go back to the relational, can we then use the relational as a way to continue to build trust? The American Academy of Family Physicians about 20 years ago did a campaign to find out the most trusted name in the US. Family Doc came number one, ahead of Disney. The only time I think we can say we were ahead of Disney. But we have then come to a point now we are looking at more transactional models. We have not built on the trusting relationship models, which I think is a very critical point when we work in communities too.
That's actually aligned with my opening speech there when we mentioned real partnership, real ideas in action, and building those relationships. I think it's very important when it comes to primary care. I'll give you the rest of time to share your hopes of the future of the primary care, and if there is any takeaway messages you want the audience to receive today, the floor is yours.
Thank you. Don't forget primary care, okay? That's number one. Primary care should be the foundational element in health systems growth. We talk about it, we don't practice it well in our own systems. That is one important message. My hope is that we equip the factories, the academic institutions in our own neighborhoods, in our own countries, to think local. Fit for purpose occurs only when you recognize the wisdom of that community.